Hello everyone. Today we'll discuss scoliosis, assessment and treatment roles of physical therapy, orthotics, and surgery. This session is aimed at medical students preparing for clinical practice. We'll cover definitions, types, assessment, interventions, and timelines. Scoliosis is a three-dimensional spinal deformity. It includes lateral curvature or coronal deviation of the spine, plus vertebral rotation and often sagittal plane changes like altered kyphosis or lordosis. Scoliosis is most commonly identified in adolescence, however it can occur at any age, infant to adult. Early detection is important for management planning. Types of scoliosis are idiopathic, congenital, neuromuscular, and degenerative. Idiopathic scoliosis is the most common, no clear underlying cause. It is classified by age of onset, infantile, juvenile, adolescent. Infantile, birth to 3 years, juvenile, 4 to 9 years, adolescent, 10 to 18 years, the most common presentation. Congenital scoliosis arises from vertebral malformations present at birth. Neuromuscular scoliosis is secondary to conditions like cerebral palsy or muscular dystrophy. These patients often need multidisciplinary care. Degenerative or adult scoliosis results from age-related spinal changes. Degeneration, osteoporosis, and disc disease contribute to curve development. Management focuses on pain, function, and alignment. Cobb's angle measures curve magnitude on an AP radiograph. It is the angle between lines of the most tilted vertebrae above and below the curve. Severity classification: mild, moderate, severe by degree. Assessment begins with a detailed history. Note age, onset, family history, pain, and functional limitations. Document progression and prior interventions. Observation includes the Adams forward bend test. Look for a rib hump and asymmetry of the trunk or shoulders. Assess pelvic tilt and limb length discrepancy. Physical exam: range of motion is measured. Test muscle strength of spinal stabilizers and limbs. Evaluate flexibility and perform a neurological screen if indicated. Imaging is essential for diagnosis and progression monitoring. X-ray with Cobb's angle is the gold standard for measuring curve magnitude. Track serial radiographs to assess progression. Physical therapy is indicated for mild to moderate curves and as adjunct care. Goals: improve posture, strengthen stabilizers, increase flexibility. Also optimize respiratory function and prevent progression. Specific exercises include the Schroth method, three-dimensional correction. It uses corrective breathing, postural awareness, and muscle activation. Sessions are individualized and require supervised training. Core strengthening and spinal stabilization exercises are central. Stretch tight muscles on the concave side to improve balance. Functional training maintains activity and independence. Postural training and ergonomic education are provided for daily life. Breathing exercises expand the rib cage and support Schroth techniques. Mirror and biofeedback tools help reinforce correction. Bracing is indicated for growing patients with Cobb angles roughly 25-40 degrees. The primary aim is to prevent curve progression during skeletal growth. Success requires adherence, often 16 to 23 hours per day. The TLSO, commonly called the Boston brace, is most used for mid to low thoracic curves. The Milwaukee brace is less common and used for higher thoracic curves. Bracing can be effective in patients with growth potential and curves under 40 degrees. Evidence shows bracing reduces progression when worn as prescribed. Monitoring fit and supporting adherence are part of PT care. Family support and education improve outcomes. Surgery is considered for curves above roughly 40 to 50 degrees or progressive deformity. Indications include progression despite bracing and significant pain or cardiopulmonary issues. Preoperative counseling covers risks, expectations, and rehabilitation. Common procedure: posterior spinal fusion with instrumentation. Rods, screws, and hooks are used to correct and stabilize the spine. The goal is correction, stabilization, and preservation of function. Postoperative PT focuses on safe, gradual mobilization. Respiratory care and breathing exercises are vital in early recovery. As healing progresses, strength and flexibility training resume. A simplified timeline guides intervention based on Cobb degree. Cobb under 20 degrees. Observe and provide exercise-based management. 20 to 40 degrees. Combine PT with bracing during growth. Over 40 to 50 degrees. Consider surgical correction with postoperative rehab. Physical therapy is integral across all stages. Decisions should be individualized and multidisciplinary. Rehabilitation aims to return patients to safe activity and function. Teach safe lifting, posture, and spine protective strategies. Provide home exercise programs and long-term follow-up plans. Multidisciplinary care involving orthotists and surgeons improves outcomes. Monitor outcomes using clinical measures and patient-reported tools. Psychosocial support is important, especially for adolescents. Evidence supports targeted exercises, bracing and growth, and selective surgery. Counseling and realistic goals improve adherence to bracing and exercises. Digital tools can support home programs and monitoring. Key roles for PT, conservative management, pre-surgical conditioning, and post-op rehab. Timing of interventions is critical to optimize outcomes and prevent progression. Always individualize care and involve the patient in decisions. In summary, assess thoroughly, use PT and bracing appropriately, and refer for surgery when indicated. Multidisciplinary, individualized, and timely interventions yield the best results. Thank you. Continue studying clinical protocols and evidence for scoliosis care. References and guideline links appear on screen. Consult them for detail. Subscribe for more clinical teaching videos and case reviews.